we're going to go into the panel discussion. We're going to hear from Dr. Ajeet Bhadoria, who is with the India Institute of Medical Sciences. I just saw Ajeet at a recent India Hepatitis Summit, and the meta-analysis to estimate the proportion of persons treated with the previous recommendations was also some of his work on this topic area. But Ajeet, welcome to our panel discussion, and so please share your perspectives to get our panel discussion going with the Q&A to follow.
Thank you so much, John, and good evening, everyone. It's 9 p.m. here in India. So I'm deeply grateful to John and Lindsay for providing me this opportunity to contribute in this crucial webinar on the implementation of WHO hepatitis B guidelines and to share India's perspective. So at this point of time, I would also like to mention that I was also the part of the guideline development group member, and Wendy was the chair of that group. And we tried to make the guidelines more, as mentioned by Maria also, it's more for physicians, more for primary care physicians, more for public health approach. So, treating maximum people to get, both incidence and mortality down in future, which are our elimination targets. So first question is, are we, National Viral Hepatitis Control Program in India, have adopted or are willing to adopt these new guidelines in India? So answer is no. Right now we are trying to stabilize the existing operation guidelines in the country, and maybe in future we'll definitely try to adopt these guidelines and expand the treatment eligibility. So we are sticking to the old WHO guidelines, and for those who do not know about the National Viral Hepatitis Control Program, it is a 100% domestically funded program in the country, which was launched 6 years back in 2018 on 28th of July 2018. That was the World Hepatitis Day. And this program commits free screening, free testing, and free treatment for all Indian citizens. And the national program is currently facing multiple implementation challenges since last 6 years, and COVID also, gave us a fall for 2 years. And I'd like to mention that these challenges, they are more for hepatitis B than for hepatitis C because of these complex guidelines which we are following. And so I'll try to enumerate few of the challenges and few of the opportunities for hepatitis B in India. So first is how to scale up the testing and screening for hepatitis B to reach our elimination targets. So according to WHO's global hepatitis report, we know that burden of hepatitis B in India is around 30 million out of 61 million in Southeast Asia region. And this is around 12% of the global infection. Diagnosis coverage is only 2.4%, and we are targeting 80%. So currently, I think it's looking far difficult to achieve that target by 2030. But definitely we have to move ahead to increase this percentage as much as possible by 2030. So currently, National Viral Hepatitis Control Program in the country, they are procuring and they are distributing hepatitis B rapid diagnostic kits. And this National Center for Disease Control is the nodal agency for the implementation of this program, and based in New Delhi, and they are the top administrator who are taking care of this program. Second challenge is, or I'll say the challenge for this scaling up of testing is mainly underutilization of these kits. So they are procuring and they are distributing without, capacity building of the medical officers. So they are not comfortable, they are not oriented whom to test. So they are mainly, if I have visited few of the primary health centers, and they're testing mainly for ANC cases, pregnant women at primary care level. In the hospitals, in the facilities, blood donors, if a person is going for surgery, they are being tested. Otherwise, these kits are not utilized and even getting expired at few centers. So data capturing is also poor. So we can't find out the hotspots in the community so that we can go and do active screening. There is very little community screening efforts for individuals, and they are mainly done by either some organizations who are self-motivated, some individuals who are proactively working on hepatitis, and by some NGOs. Otherwise, community screening is very nil, I'll say almost zero. We are just doing passive screening of hepatitis B. The positive thing for scaling up is that National AIDS Control Organization, who is doing a lot of good work for HIV, they have included hepatitis C screening along with HIV screening with their bio-behavioral survey, which they do at a mass level. And also inclusion of this hepatitis B and hepatitis C in our national family health survey, which is a huge survey done all over the country. So these two are the promising steps to increase the scaling up of testing. After testing, the second challenge is hepatitis B virus DNA, so which is not uniformly available in the country. So National Viral Hepatitis Control Program, they are providing funds to states, and now the states are given the responsibility to find out their own methods to test for hepatitis B virus DNA in their respective states. Like if I talk about my state in Uttarakhand, so we are running on a public-private partnership mode, and we have identified one private lab who's doing all the diagnostics for all diseases in the state, and they submit the bills and they submit the invoices to the state government, and then they pay. So if I'm a physician sitting at a primary health center level, I'll write hepatitis B virus DNA testing required. The blood will be collected by one of the person lab technician, and then I'll get the report. So it's quite simple in Uttarakhand, but it's different in all different states. So that should be uniform throughout the country. Third challenge is, again, as we are adopting the old guidelines, the treatment eligibility assessment. So we are doing fibrosis assessment, APRI, DNA, hepatitis B, E antigen still plays a crucial role in the treatment algorithm. We are assessing for ALT also. So the primary care physicians, they are finding it difficult to do this treatment eligibility assessment. So what they are doing, they are just referring the patient to a higher center for treatment of hepatitis B. And things are different for hepatitis C, but for hepatitis B, it's same. Regarding drugs, everything is provided free, procured. Tenofovir, TDF, and entecavir is procured and distributed by the nodal agency to all states. But same problem with the drugs also, underutilized, sometimes expired also, and medical officer, they are not comfortable in treating because of this treatment eligibility assessment criteria. Then comes the fifth challenge, which is retention to care. So this is for both those who are treatment eligible on treatment, and also for those who are not treatment eligible, and we want them to come for regular follow-up. So we have done one systematic review and meta-analysis that was a WHO commission with the University of Liverpool and University of Howard, and the results was that even in the hospital-based specialist care settings, the retention of care for those who are on treatment was only 50%, and it was only 35% for those who are on follow-up without treatment. So that's also a huge challenge for keeping the patient in care after they are diagnosed and they're put on long-term treatment or not put on long-term treatment and advised to come for follow-up. Sixth challenge is prevention of mother-to-child transmission. Hepatitis B birth dose plays a very important role, and the coverage is promising, showing increasing trends, but still it is stuck at around 63%. And we want to achieve the elimination target and increase the hepatitis B birth dose in the coming future. ANC screening is universal. Every pregnant woman is getting tested for hepatitis B surface antigen. Treatment eligibility is again the older criteria. If the hepatitis B virus DNA is more than 200,000, then we initiate treatment. Otherwise no treatment. And coverage for hepatitis B 3 doses is very good. It is more than 90%. So that's good. Otherwise, hepatitis B birth dose is the biggest challenge. Then comes the importance of private partners in the country. 50% of our community is still going to these private partners. So they are not pooled in the national program. So we are not getting the complete data. Those who are treated in private sectors, we don't have that data from the private sector. So I think program should find out how to pool them in. In the Indian Hepatitis Summit, a few of the states, they have shared that they have made hepatitis B a notifiable disease. So when you make a disease a notifiable disease, then even a private sector, they have to notify it to the government. So I think that's a good idea. It should be notifiable throughout the country if we don't want to miss out any hepatitis B case if treated in private sector. Then the challenge is data capturing. So I'm really thankful to Clinton Health Access Initiatives. They've developed a great, robust data collection platform for us, which also has an interactive dashboard. But the problem is there is no dedicated data entry operators. So data entry is either not done, or done, then it is mostly incomplete or inconsistent. And it is not sufficient to document the cascade of care which we need for hepatitis B and for hepatitis C also. Then stigma and discrimination is still there in the country, and people are suffering. They're not coming for screening. So community mobilization is very important if you want to mobilize people for hepatitis B care. So I think we have to think about how to reduce this social stigma and discrimination also in the country. Last but not the least is operational difficulties, implementation difficulties, which the program is facing throughout the level of cascade of care. So I think from last 6 years we have this program. So I think it's a fertile ground in the country to do operational research, identifying challenges, finding solutions, strategies, and then testing these solution strategies using either pre-post experimental design or a quasi experimental. I mean to say some operational research design which can help us to generate evidence and for specific intervention which can improve the testing, which can improve the testing uptake. We are talking about reflex testing. We are talking about multiple strategies, but I think these need to be tested in ground in pragmatic approach so that we can have some data for the country. And I really appreciate the core HBV initiative, which is a Center for Operational Research initiative by the Coalition of Global Hepatitis Elimination to promote and support operational research. So in India, as mentioned by John, I am based at All India Institute of Medical Sciences. So we have 20 functional All India Institute of Medical Sciences in the country, and they come in effect to reduce the regional imbalance in the country. So I can coordinate with all these aims, and we can plan and execute multiple operational research in India, as we are struggling to implement this National Viral Hepatitis Control Program, which is the largest 100% domestically funded national program. And I think it's a very promising program in the country. And I really hope that it functions, for the betterment of the people, as we are doing for HIV, malaria, and tuberculosis in the country. So thank you, everyone.
Thank you.
I'll be happy to take questions.
Thank you very much. We'll get some questions. You raise a number of issues. I know Maria has to leave here in about 5 minutes for another meeting, but Maria, just wanted to, first question popped in my mind was, how is does Spain have national treatment guidelines, number one? Do the WHO recommendations serve to influence those? And I know, you're involved in EASL, and I just ask you to give a status of EASL's updating their guidelines, perhaps with the WHO guidelines as a baseline of information. Thank you.
Yeah, thank you for the question. EASL is updating the hepatitis B guidelines, and I think they are going to launch the guidelines at the next EASL meeting in Amsterdam. The new guidelines approach will be increase the number of patients that can be treated. So it will be less restrictive, in my understanding, for starting, are still under the final process of development. But I think it's really important to know that the majority of guidelines for associations working in liver diseases are more focused on pathologists, on physicians, experts, than in policy makers. And for this reason, for me, are extremely important, the WHO guidelines, because they push policy makers for screening, for treatment, and at the end for hepatitis B elimination.
Mm-hmm. Thank you. And we'll turn it over here to Cal in a moment, but Ajeet, you raised a number of issues that are that need to be overcome to expand access, but you brought up several times how your national treatment guidelines are still based on the previous WHO guidelines. So is there a process underway to update the guidelines in India, or is that still an activity that needs to get started?
John, I think as much as I understand, there is no such discussion going on. I mean, in the coming, I'll say, a few months, or maybe this year, we'll not be able to get such kind of any good news that it's updating. So we are really hopeful, and there are many people who are advocating that we should expand treatment and we should adopt WHO guidelines, or at least try to go for some expansion in the treatment eligibility. But still, there is no response from the government, no steering committee meetings, no technical working group meeting. I'm the part of it. So we have not met, I think, from last 2-3 years. So So this is really not clear to us whether there is any plan from the government to update the guidelines.
Yeah. All right, thank you. We can get back to that. Now let me turn it over to my colleague, Dr. Calvin Pan, who's at the New York University School of Medicine in the United States, and has done clinical research regarding hepatitis B in the U.S. and in China, and look forward to his perspectives on expanding access to hepatitis B. Cal, over to you.
Thank you, John. Thank you for inviting me. So for the time interest, I just try to emphasize a few points that what we learned from WHO as American AASLD under the way of developing a new guideline. And we noticed that the WHO guideline writing group take a different approach is the public health effect, considering the easy implementation of taking care of hepatitis B patients. But like Dr. Buttu just mentioned, the European guideline and the American Association guideline would be a lot more leaning forward to the individualized care, which you could have the luxury of utilize the other good resource, including DNA testing, including diagnostic tool for severe fibrosis. So my point is, if you look back for the guideline development, the AASLD will stick with the restrict graded evidence-based guideline, and European Association guideline, now the new version, would towards the expert consensus. They're all evidence-based, but it would take a little bit difference in terms of how to interpret the evidence and how to reach the final decision. And the public health approach like WHO could overtreat some patient, but it will benefit the implementation and also reduce, significantly reduce the mortality and liver cancer. So bottom line is, would AASLD EASL guideline would be similar to WHO? No, because the different settings, different practice resource, and also the guideline development process is different. But I think back to 2022, three associations did have a conversation of how to harmonize those guidelines. In my personal view, something we should do together, for example, the definition of a disease phase, and those things is not that much leeway to interpret it differently. But treatment approach, it could be different. However, what we learned from WHO guideline in America is I have noticed the community start to implement some of the treatment criteria. For example, in Asian community, patients have no resource, no insurance coverage or undocumented. They start to treat those patients without testing, right? So based on the loose criteria. And AASLD during the developing of new guideline actually could take a more close look on the public health effect. When they assemble the evidence, there is a process you may all familiar with, is the evidence to decision framework. During that process, we have to consider the implementation element of any recommendation and also the public health effect, cost effectiveness. So that WHO, whatever their analysis actually have been shared with AASLD, and the group have looked into it. Of course, the guideline is still in the development. I cannot disclose anything, but the process have started and try to take more close look on the implementation. And AASLD guideline committee also involved patient advocacy group. They have a representative in the group. So those things actually would put a positive impact in the AASLD guideline development. Besides the guideline and implementation, I think Dr. Bhadoria actually mentioned many challenges during the implementation. I work with Asian countries a lot. I also noticed those challenges, but two things I want to express my concern is There are so many challenges, but you can only do one or two things at a time. If you want to have limited resource to solve the problem, I think two things I pay attention to. For those audience in front of the camera, you probably can look into your local setting and try to advocate two things, in my opinion. Number one is you have a role in influence policymaking. Focus on screening and linkage to care first. Just like Dr. Ward just presented at the very beginning, if you look at the global diagnostic numbers and treatment numbers, you have 10% patients diagnosed with hepatitis B, only 2% treated. So even all the guidelines now sit down together, we agree with the most liberal criteria to treat, just like Chinese guideline, they treat everybody. So you probably can improve 50% of the untreated patients, right? That 8% not treated, and you increase 4%. Then you got 6% gain. But look at that 90% hasn't been diagnostic, evaluated. Those patients, you're actually fishing on the wrong side of the boat. So this is my first key point that I want to mention is no matter how hard the Ghana are working on expanding the treatment indication, it's not as a good fact that you can motivate the local resource and policymakers and start massive screening and identify those patients first. The second thing is the mother-to-child transmission is still contribute over 1 million new infection every year. And if you look at the dynamic of the disease globally, those patients have been infected. You cannot change that much except by provide effective treatment. But if you prevent a new infection, and the elimination goal would be easily to get achieved. So for mother-to-child transmission, even the newest guideline, WHO said that you can treat any surface antigen positive mothers without testing HBV DNA. My point is you need to treat them earlier. Whenever you see them, treat them. Because if you look at the global burst dose coverage for vaccine, don't mention about HB, in a lower middle income country, it's very minimal. There is rarely you can find a country get a burst dose. So if you still stick with the so-called huge evidence-based 200,000 IU third trimester treatment, that's not the reality. You're going to get a lot of infection. So the reality is treat everybody when they see them, forget about the HBV DNA and just treat them. That way you can reduce the viral below 20,000. More likely the vaccine will work, even not the burst dose. But even at 2,000, preferably you should give a burst dose. But given there is no burst dose, then if you want to achieve 20,000, the threshold, you must treat mother at least 6 months. We just have a new publication with our HBV study. So this is something important message that I want to bring up to the group. You treat every mothers when you see them because likelihood in the lower income country, you don't have burst dose of vaccine. Don't even think about HBV. I hope those would help you to think, rethink the whole thing of elimination.
No, thank you very much, Cal. I know we're running a little short on time, but I know you're very involved in China, doing a variety of different studies there. And I know China, liver associations have come out with national guidelines for hepatitis B treatment that are a little bit different than the WHO guidelines. Can you briefly describe those, please, just to help people understand that they're available?
Yeah, the guideline actually have an English version of Operation Clinical and Translational Hepatology. Mainly three things. They expand the treatment criteria to any Hep B surface antigen person who are age over equal 30 or greater than 30 with any detectable HBV DNA, regardless HBV DNA level and ALT level. Of course, cirrhotic, everybody would agree to treat with that, but even non-cirrhotic. that criteria actually can give you the indication to treat any adolescents. You just don't need anything. So that's the most liberal criteria by far by any national level of guidelines. And the second thing is I did involve in their guideline development and also a new pediatric guideline and suggest that you should test the influenza earlier, not waiting for 1 year, but preferably 6 months or even earlier, because the early treatment of pediatric population, there are data suggests that they have somewhere between 30% to 50% functional cure rate. If you treat them before age 2, that decrease after age 6. So those are the new developments, I think, because given the high prevalence of hepatitis B in China, when they move very aggressively, taking a public health approach. Is it a great evidence support? Probably not, but it will benefit. It will reduce the outcome of cancer and cirrhosis.
Thank you so much. You raised an important point about the really key intervention of screening, expanding access to screening, and then improving access to care. And Ajeet, you mentioned that as well. And there's been a lot of comments in the chat regarding point of care testing for HBsAg and the fact that that's not available in the United States yet. Just wanted to see if you and Wendy wanted to comment on how that's being used in your countries, and then finish up if Cal has some perspectives on point of care testing for HBsAg. Over to you, Ajeet.
Okay, so John, like we have rapid diagnostic kits available, and they are being utilized in the clinics. So mainly the patients who are coming to primary health centers, community health centers, district hospitals, or other hospitals, they are being tested by these kits. And if I talk about my center, so we are doing the detailed analysis of all those who are coming positive, and we have identified 2 or 3 hotspots in Uttarakhand state, and we go and then we do active screening also using these kits. Other than using these kits in the community, second important is family screening. In hepatitis B patients, family screening is also very important. So whenever we get a person who is hepatitis B positive, we screen the parents, siblings, wife, spouse, and the children. So all they are screened not only for hepatitis B surface antigen, but also for anti-HBC core, and if it is positive, then we go for hepatitis B DNA also. Sometimes we get occult hepatitis B also. So point of care testing is available, and we are trying to use it. Mainly it is used in the facility. Some institutes, they are going out and doing some community screening camps also, but family screening is also very much promoted, but it's also institutional.
Thank you so much. Wendy, is point of care HBsAg testing available in South Africa?
Point of care is available. It's still very limited, but what they are looking in terms of actually updating our guidelines towards the WHO is actually implementing the rapid diagnostic tests. And our approach really is, obviously population screening is expensive, but using the pregnant women as the index to screen, then recommend screening the partners, as I just said, the family, and really utilizing that as a sort of a more cost-effective way of actually screening and diagnosing and linking to care. And that's been, so far, the uptake has been good.
That's great. I'm glad you both raised that aspect of extending treatment, screening into families, given the high likelihood that other family members will be infected if one family member is HBsAg positive. It's really a very key intervention that's underutilized this moment. It's great to see that's underway in your countries. Do you think there's a role for point of care testing for HBsAg in the US, Cal?
Yeah, you brought up a great question. Let me take one step back. Since we are focused on the middle and lower income country, and China is one of them. And from China, I'll move back to USA and talk about that. So in China, actually, there's a lot of development efforts on the rapid testing. And lately, I got involved in one of the projects is use the CRISPR to detect HBV DNA using RNA, which the paper have been published. You can search for that and developed by Beijing Capital University, and really driven the cost of close to nothing. It's like 5 RMB is less than $1. I think it's in no doubt in my mind, it would be easily get adopted in a country to replace HBV DNA and with very good sensitivity and accuracy. Now, since this is a global conference and including John, yourself, and the others advocacy group, what I would suggest is if we can group everybody together and try to work on a universal pattern or approval across every country, if we can move this campaign as an advocacy group, that will solve a huge problem. There are a lot of very high advanced technique from China or the other countries, but the major barrier is the pattern and the approval of local countries, because those tests actually is very, very low profit, right? There is no financial support to try to go through this complicated licensing process. If our group can work together with the other group to make sure at least for this, the point of care testing or rapid testing can be easily adopted by every country. If the authority go through WHO or whatever channel can approve that, I think it will make a huge impact. There is available. So back to the US, the point of care testing definitely is a great replacement of lower cost testing. And now you know that the insurance premium is sky high, right? And our Americans suffering from health care benefits, not getting enough benefits. So that will control the cost. I do believe that there is a huge role here. But again, the licensure process, nobody would be able to step in with paying a huge cost of licensing.
Yes.
That's my point.
No, you're absolutely right. I know in our own work in Africa, just every African country having their FDA equivalent and the cost of going from one country to the X. And we talked to Africa CDC about having a regional approach, for example, rather than a country approach. So that's a very key area.